She was 54. The chart said severe depression, admitted voluntarily. On day 3, she stopped eating. When I sat with her, she explained calmly that her stomach had rotted inside her weeks ago, that her blood had stopped moving, and that she was, in the technical sense, already dead. She was not distressed. She was patient with me. Her vitals were normal. Her MRI was unremarkable. I could not tell her why she was wrong. I have been a physician for 19 years. This is one of the cases I cannot explain. Her case is not new. It is, in fact, very old. In 1880, at a meeting of the Société Médico-Psychologique in Paris, the French neurologist Jules presented a patient he called Mademoiselle X. She denied the existence of her brain, her nerves, her chest, her stomach, and her intestines. She believed she had no soul, that God did not exist, and that she could not die a natural death, because she was already, in some fundamental way, not alive. Named the condition le délire de négation, the delirium of negations. For over a century afterward, psychiatrists across Europe, North America, and Asia have continued to describe patients who present with almost identical convictions. The most cited epidemiological work remains Berrios and Luque, published in Acta Psychiatrica Scandinavica in 1995. They analyzed 100 published cases across more than a century of the literature. 45% of patients presented with delusions of non-existence. 55% expressed a belief in their own immortality, a paradox that only coheres from inside the delusion, because if one is already dead, one cannot die again. 89% were in a severely depressed state at the time of presentation. A later systematic review by De Bruyne and Oudenaardt, published in Neuropsychiatry in 2012, confirmed the pattern and added that the condition appears across every cultural context in which it has been sought. The delusion exists on a spectrum. At the milder end, patients describe feelings of emptiness, emotional death, a conviction that something essential has gone out of them. At the severe end, they report that specific organs have decayed, that their blood has stopped, that their body is putrefying. In a case series published by Ramirez Bermudez and colleagues in the Journal of Neuropsychiatry and Clinical Neurosciences in 2010, several patients could smell their own decomposition. One described insects moving through the cavities of his abdomen. These are not metaphors offered by the patient. They are reported as straightforward physical facts. The condition is not, formally, a diagnosis. It does not appear in the DSM-5 or the ICD-10 as a standalone entity. It is classified as a symptom, a presentation that emerges against the background of another illness, usually severe depression, sometimes schizophrenia, bipolar disorder, or a dementing process. Sometimes, as we will see, a discrete lesion. The danger is practical and immediate. If you are already dead, you do not need to eat. You do not need to drink. You do not need warmth or medication or sleep. Patients have starved. Patients have suffered fatal metabolic collapse inside hospitals that were actively trying to feed them. The delusion, quietly, kills. The mainstream explanation is not dismissive, and it should not be caricatured. It is, in many respects, compelling. The standard model conceptualizes as delusion as a two-factor delusional misidentification syndrome, in the framework proposed by the cognitive neuropsychologists Max Cotard and Ryan McKay. The first factor is an abnormal perceptual or affective experience. The second factor is a failure of the belief evaluation system, the machinery by which a healthy brain rejects implausible explanations for its own experiences. S, in this model, is the mirror image of Capgras delusion. In Capgras, a patient recognizes a loved one's face, but feels no emotional resonance, and concludes that the person is an imposter. In ES, the same affective flattening is turned inward. The patient looks at their own reflection, their own body, their own autobiography, and feels nothing. The brain, demanding an explanation for that absence, produces one. I must be dead. Neurobiologically, the candidate circuit is reasonably well mapped. The fusiform gyrus, in the inferior temporal cortex, handles face and self-recognition. The amygdala and the anterior insula attach affective salience, the feeling that something matters, that something is mine. Dysfunction in the connections between these regions, particularly involving the right hemisphere, produces the flat, derealized quality that patients describe. Neuroimaging in small case series has shown frontal and parietal hypometabolism, right hemispheric lesions, and generalized atrophy, though, importantly, no single consistent structural finding. A PET study reported by Charlene Verville and colleagues in 2013 described profoundly reduced metabolic activity across much of the cortex in a single ES patient. A scan the authors compared carefully to patterns seen in vegetative states. The skeptical, philosophical voice is well represented. Anil Seth, at the University of Sussex, argues that the self is a controlled hallucination, a predictive model the brain constructs and continuously updates. S, in his framework, is what happens when the interoceptive prediction machinery fails. The brain stops generating the background signal of being alive, and the patient's narrative self, quite rationally, concludes the obvious. Michael Schur-Mayer has cited similar cases as evidence that the sense of existing is itself a neural construction, vulnerable to the same breakdowns as vision or memory. Thomas Metzinger, the philosopher at Mainz, has argued that the phenomenal self-model can decouple from its biological substrate in precisely this way. The treatment literature supports the mechanistic view. Patients respond, sometimes dramatically, to antidepressants, antipsychotics, and, when those fail, to electroconvulsive therapy. A review by Sahu and Josephs in the Journal of Neuropsychiatry and Clinical Neurosciences in 2018 reported ECT remission rates above 80% in refractory cases. The delusion is, in that sense, biological. It responds to the same tools we use for other disorders of brain function. This is a coherent account. For most of my patients, most of the time, it is adequate. It is also, I have come to believe, incomplete. The cases that unsettle me are the ones where the mechanism is clear and the content still is not. Consider a case reported in the Journal of Neurology, Neurosurgery, and Psychiatry in 2015. A 50-year-old man with a history of traumatic brain injury developed the conviction that his brain had died while the rest of him remained alive. SPECT imaging showed reduced perfusion in his frontal and parietal cortex, bilaterally. The mechanism, in a sense, was legible on the scan. But consider what the patient was doing. He was using an intact brain to articulate the proposition that his brain was dead. He was employing working memory, syntactic construction, semantic retrieval, theory of mind. He knew I would find the claim strange, and he anticipated my objections, to deliver a verdict of his own non-existence. The faculties required to generate the delusion were the very faculties the delusion denied. Or consider a case series published by Yamada and colleagues in 1999, following 3 patients with right parietal strokes. Each developed its features within days. Each recovered, partially, over months. During the acute phase, each could describe, in detail, the room they were in, the date, the names of their children, the circumstances of their admission. They could do arithmetic. They could follow a conversation across 20 minutes. And they maintained, throughout, that they were dead. The question is not how the brain generates the feeling of unreality. We have reasonable answers for that. The question is why the conscious system, presented with overwhelming sensory and cognitive evidence of its own operation, accepts the nihilistic conclusion instead of the obvious one. This is where my patient returns. I told you her MRI was unremarkable. That was true. Her EEG was also within normal limits. Her metabolic panel, her thyroid, her B12, her inflammatory markers, all clean. There was no lesion to point to, no circuit I could draw on the whiteboard. Her depression was severe, yes, but I have treated hundreds of severely depressed patients. They describe hopelessness, worthlessness, a wish to die. They do not describe the completed fact of being dead while asking the nurse, politely, for a blanket. When I sat with her on the 5th day, I asked her, carefully, how she knew. Not whether, but how. She thought about it for a long time. She said she could feel the absence. She said that when she tried to locate herself, her body, her presence in the room, there was nothing there to find. She said the strangest part was that the nothing was specific. It had a shape. It was clearly her nothing, and not someone else's. This is the detail that the standard model has the most difficulty with. The flat affect hypothesis predicts emptiness. It does not predict a structured, first-person, reportable phenomenology of one's own non-existence, a nothing that nonetheless belongs to a specific someone. To report that, the patient must have intact language, intact introspection, intact self-reference, intact temporal continuity, and an intact capacity to distinguish her experience from another's. Every one of those faculties was, demonstrably, operating, and all of them were operating in service of the claim that none of them existed. I am not saying this is supernatural. I want to be careful. I am saying that the instruments we have, the MRI, the EEG, the PET, the rating scales, measure the correlates of the disturbance without touching the thing the patient is actually reporting. We can show you a hypometabolic frontal lobe. We cannot show you what it is like to be inside one and to have concluded, from inside, that you are not. What would it take to actually answer this? There are serious people working on it. At the University of Sussex, Neil Seth's Sackler Center for Consciousness Science is running protocols combining interoceptive tasks, heartbeat detection, or breath tracking, with functional imaging in an attempt to identify the neural signature of bodily self-presence, the background hum that tells a healthy brain that it is alive and located. At the University of Liège, Stephen Lauries and his Coma Science Group have built some of the most sensitive protocols for detecting residual consciousness in unresponsive patients, and have begun extending those methods to psychiatric presentations of disrupted self-awareness. At the Allen Institute, Christoph Koch's group continues to test integrated information theory, Giulio Tononi's framework, against cases where the reported phenomenology diverges sharply from the measurable substrate. The Templeton-funded Cogitate Consortium is pitting theories of consciousness against each other in pre-registered trials for the first time in the history of the field. None of these programs yet has an instrument that can tell us what it is like to be the patient in the bed. We can measure the brain, we can measure behavior, we can measure the patient's report. What we cannot measure, directly, is the first-person experience the report is about. The gap between the scan and the testimony is not a gap in funding or resolution. It is a gap in the category of thing we know how to detect. This is the argument underneath everything I make on this channel. Medicine recognizes 4 vital signs: temperature, pulse, respiration, blood pressure. A 5th signal, the presence, continuity, and coherence of first-person experience, governs whether the other 4 matter at all. and we have no direct instrument for it. We infer it. We proxy it. We ask the patient, and we trust the answer. In delusion, the patient is telling us, with every cognitive tool intact, that the fifth vital has gone to zero, and we have no way to check. What current medicine cannot do is this. It cannot tell me from the outside whether my patient's report is a mistaken inference from a flattened affective signal or an accurate report of something genuinely absent that our instruments are not built to detect. Both possibilities are, at present, consistent with the data. The treatment algorithm, antidepressants, antipsychotics, ECT, works well enough that we rarely have to choose between the two interpretations. But the fact that we do not have to choose is not the same as the fact that there is nothing to choose between. The honest position is that we are treating a condition we can describe with extraordinary precision and explain only in the general terms of circuit dysfunction. The patient knows something about her own interior that we do not and cannot access. The most we can offer is to bring her back to a state in which the question no longer feels pressing to her, which is not the same as answering it. She improved. I should tell you that. Her name, on the chart, was Margaret. She was a retired librarian. She had 2 adult sons who visited her, carefully, every afternoon during the 3 weeks she was with us. She had been a competitive swimmer in her 20s, and she kept, in her handbag, a laminated photograph of herself at a regional meet in 1989, which she would occasionally look at and hand back to the nurse without comment. After the 6th ECT session, she ate breakfast. She did not announce it. She simply picked up a spoon and ate a small amount of oatmeal. And when I asked her later whether she still believed what she had believed, she said she was not sure anymore. A week after that, she said she had been mistaken. 2 weeks after that, she went home. I have tried, in the years since, to decide what happened to her. The standard account is that a depressive episode distorted her affective processing, that her brain generated a nihilistic interpretation of that distortion, and that electrical stimulation of the cortex reset the circuit. That account is probably correct. It is the account I would write in a chart. It is the account I would teach a resident. But I remember sitting with her on the 5th day, and I remember her telling me, with great patience, that her nothing had a specific shape, and that it was hers. I do not know what she was reporting. I do not know if our instruments, as they currently exist, are built to find it. I know she came back. I know I do not fully understand where she had been. And I know that the distance between those 2 sentences is, for now, the distance at which I practice.